What's going on, guys? Welcome to the newest episode of All Things Locks, the show where we discuss everything related to leadership, operations, culture, and strategies for growth. Now, today we're talking about something that honestly doesn't get discussed really too much in healthcare, which is how do you respond to failure? Now, we're going to be bringing on Dr. Daniel Eiferman. He is a award-winning doctor, Castle Connolly, every year since 2018. He's an acute care surgeon. He's a tenured professor at Ohio State. And we're bringing him on the show because he is going to be talking about what happens when you do a surgery and you don't get the outcome you're looking for. What happens when there's complications? And this episode is not just for orthopedic surgeons. This is for every person who's got their hands on a patient. Maybe you're a physical therapist or a chiropractor. Patient doesn't get an outcome you expected. How do you respond to that? Because your response dictates not just what happens with your own career, but what happens with the next, crop of patients that you're treating. So he's going to be going over how to not just survive, a procedure where there's complications, or how to survive you didn't get the outcome you're looking for, but he's coming on to really talk about how do you thrive? How do you grow? How do you use this as a learning opportunity to make yourself a better clinician, a better doctor? So you guys don't want to miss this. I'll see you there. Yeah. So we're just going to get started here. So Doc, we spoke a few weeks ago, and I really love the topic you're talking about. I mean, you have a lot of things you're really discussing these days, but I really want to hit on something that doesn't really get discussed too much in medicine, which is what happens after the effect of a complication going, during surgery, or maybe just, what happens when you do a textbook surgery and you don't get the desired outcome. So I really wanted to kind of kick us off with that, and more so in the sense of, when you go to medical school, you get this long education, especially being a surgeon. It's not obviously a 4-year education. You're there for a long haul, which but it seems like there's not a lot of preparation for what happens in that instance when things don't go just right. So what do you think maybe has to change, or what do you think we need to do a little bit better to actually start prepping doctors for really the inevitable that's going to happen?
You're in the good, you're going to be fine. It's going to be okay. And they think that that's what they want in their surgeon or their proceduralist. And in the short term, that is a good thing. It'll make you feel good in the short term. But if something goes wrong, it's really hard to regain the trust back, because it's like you said everything was going to be fine and all that. What I've learned and through teaching different classes and working on my own communication and listening skills is that actually the more tentative that you speak, the more oomph that you have. The people are more likely to listen to you and believe in you and trust in you when you speak more tentatively. And I think that a simple thing that we can start with is teaching people to talk that way to patients. Because when you speak tentatively, what your underlying tone is saying is, I don't know everything. I think my way is the best way to handle this situation, but I'm open to the possibility that there are other perspectives and other things that could happen. Now I'm a human being, okay, instead of some machine that's doing a procedure on you. And I think that builds trust.
Can I, for a second there, when you said the word tentative, to me that almost paints a picture of somebody who's maybe a little unsure of themselves. And I know I don't think that's what you're saying, but that's what I think the interpretation could be. So how would you differentiate that for that? For a second there, when you said the word tentative, to me that almost paints a picture of somebody who's maybe a little unsure of themselves. And I know I don't think that's what you're saying, but that's what I think the interpretation could be. So how would you differentiate that for that person who says, all right, that actually makes me think that a patient's not going to come back because they think you're not so confident that you can help them?
Which one do you think matters the least?
Words you say?
Yeah, the words you say. They say it's about 8 to 10% or so. 60% is your body language, and about 30% is your tone of voice. And so you're right. Maybe tentative isn't the right word, but what I meant is not speaking in absolute terms of and being so authoritative with your tone of voice, but rather inviting in, questions that you may have, or concerns that you may have. And that way, when I speak tentatively like that, Dan, tell me more about that, or Antonio, what's going through your mind right now? What doesn't make sense? Versus just saying, I'm the right guy and you're going to be okay. I think if we can teach people that type of communication style, then if things don't go right, we have a trust, we have a connection between each other. And the number one thing that hurts actually on the patient side of things is they don't want to feel abandoned after something bad happens. And if we don't have that connection with each other, it's hard to establish that after the fact. So that's my answer.
Let me ask you a quick question, because there's a huge disconnect with a lot of healthcare professionals, especially doctors, with regards to empathy. And that's obviously something that patients are looking for at a very high level. Do you think that plays a role in this aspect of not being able to just maybe ask those right questions, or just propose those alternatives of, hey, this might not go 100%, or I'm confident this can go 100%, but here's the potential for it to not go right, or just maybe not get the result you're looking for?
Having bad news about a diagnosis. So empathy is the shared experience from a personal standpoint. What I would say is they say the number one trait in a healthcare provider is curiosity. And that's what we are trying to do at baseline as physicians, right? How long have you not been feeling good? Where does it hurt? Different things like that. But in terms of forming that connection with somebody, it's not the empathy that matters, it's what matters to them. And so instead of saying that you could have bleeding and infection or damage to adjacent structures, they want to talk in terms of like, will I be able to play with my dog, pick up my grandkid, go to the football games? If you can learn to talk to them on those levels and you'll have that connection with them, then we know what the common goal is. I'll use my medical expertise to try to get you to that goal of playing with your grandkid or taking your dog or to walk in the park. And we usually, truth be told, don't take the time to do that because I'm focused on the clinical outcome of don't have a bleed, don't have an infection, don't need to go back to the operating room. And that's not always what the priority is to the patient. That's where I think the key is.
Gotcha. Well, one thing I'm curious on too, just myself, is when you are, working with other physicians, when you're working with other folks, is this? Gotcha. Well, one thing I'm curious on too, just myself, is when you are, working with other physicians, when you're working with other folks, is this something that's like the natural progression with doctors as they get older with experience? Like, hey man, like maybe I shouldn't be like, I'm the guy, there's nobody better than me in being, and knocking out this surgery. And just naturally over time, they're like, hey, I should be a little bit more endearing and more curious. And that actually works better. Is that a natural thing that people experience? Or do you feel like they kind of need to get coached at an earlier stage in their medical career to actually have that skill set?
Who's making sure that we're advancing and keeping up, with what's new and how to develop ourselves personally and professionally? And my answer is no, you need somebody to help you develop those skills, that it does not come naturally.
What do you feel like it's getting better or worse with younger physicians? Do you feel like this is something that generally like more people are catching up on? Like, hey, I do maybe need to get a mentor earlier, or I got it. What do you feel like it's getting better or worse with younger physicians? Do you feel like this is something that generally like more people are catching up on? Like, hey, I do maybe need to get a mentor earlier, or I got it.
Below us, I think the generation.
Yes, that's what we're talking about.
Guys aren't going to know how to operate and take care of patients. And now that I'm mid-career, some of those thoughts are creeping into my head. I don't know if the next generation. How much trouble are you wanting me to get in here?
Oh, we're full blown CNN coming in, NBC, and be like, this guy, Danny. No. So because I think it's a really real thing where I think the more that it's discussed, where really at the end of the day is like, okay, what makes you a good doctor? What makes you a great doctor? Oh, we're yeah, full blown
Yeah, as much as you can
CNN
tolerate.
coming in, NBC, and be like, this guy Danny. No, no. Because I think it's a really real thing where I think the more that it's discussed, where really at the end of the day is like, okay, what makes you a good doctor? What makes you a great doctor? And being a great doctor means having a little bit of damn humility and actually seeking out counsel earlier is going to make you greater over time.
Much focus right now.
That's my perspective, if that helps.
The term work-life balance. Now the more PC term is work-life integration. And my concerns right now, in order to do surgery or any procedure, you have to do it over and over again, right? Good judgment comes from experience. Experience comes from bad judgment. My concern is, you're supposed to laugh at that, by the way. There you go. Thank you. My concern is that the work ethic isn't there as much anymore with the younger generation. And there's been a lot written on Gen Z and things like that. Like they graduate college and they want a managerial position, like right, or some sort of leadership position right out front.
Oh yeah. Yep.
And I do have concerns that people, in order to get good at this, you have to put in a lot of the reps, as well as you got to put in the reps on the size of growing professionally, having insight, asking for help, things like that. I'm not sure if we're there yet, to be completely honest.
Well, let me ask you on that, because I do think there's this aspect that the students coming out, they're not really fully prepared for what reality is. And I know you can probably say that about every generation, but it doesn't. Well, let me ask you on that, because I do think there's this aspect that the students coming out, they're not really fully prepared for what reality is. And I know you can probably say that about every generation, but it doesn't seem that there's enough preparation for, all right, here's what, to your point, hey, you want to work 40 hours, but you're a surgeon. This is the realities of what you're actually going to have to do. And there's obviously been, just in the last few weeks, a huge talking point about the amount of physicians leaving, quitting after being in the field for only 5 years. And then we combine that with how many doctors are going to potentially leave in the next 5 years. So it's who's filling that gap. Where do you think this component plays a role with that? And not just maybe how to overcome failure and some issues that you weren't prepped for, but just the aspect of how do we prepare people for what the reality of being a surgeon actually is?
It's hard to imagine what it's like when your name is on the bottom line. Because even when we do our 5 years of training, that's what general surgery is, you're still operating under somebody else's name. And I will tell you that once you get out and you see your name as the bottom line for the first time, that's like, ooh, like the buck starts with me. And I don't know how to prepare necessarily people for that. One of my favorite lines that my mentor gave to me was, your first 2 years of being an attending, being staff, is like a super fellowship with a really good salary. Your pay goes way up, but it's like, God, it didn't look like that when I was in training. I can't get it to get the same outcome as Dr. X. I don't know of a way to prepare people other than to do it, and then to have mentors, and coaches above you that you can bounce things off and be like, yeah, I made that mistake when I was young, try to avoid this. I don't know any way around that. The thing that I do think we could have some control over is the way that we talk to each other, and the culture that if you're brand new and you have a complication and your confidence is hurting, how do I talk to you to let you know this happens to everybody, and what you feel right now is normal, and we're going to get you back up on the horse. And I don't know if we do a great job with that.
Can we expand on that a little bit of just what happens psychologically to a surgeon after those complications that maybe most people never get to see? Things around shame or guilt or self-doubt, and it's basically executional performance. And so can we expand on that a little bit of just what happens psychologically to a surgeon after those complications that maybe most people never get to see? Things around shame or guilt or self-doubt, and it's basically executional performance. And So can you elaborate a little bit on like what happens to those doctors that do take a level of ownership that like, oh man, like I really screwed up and I'm scared now. Can you kind of what happens psychologically and also what that conversation is like when you're engaging with a doctor like that?
There's really 4 outcomes after that. One outcome, or 2 of the outcomes we say are PTSD. You never get back to the level that you were performing at before. And that can have different levels of, we use the term succumbing. Those are people who have, maybe, suicidal thoughts, don't want to go back to what they were previously doing and become more risk adverse. Those are 2 outcomes. We have resilience, where you get back to the level that you were functioning at before the bad thing happened. The one that I hope that we can build a culture around and teach people to do is what's traumatic stress disorder, but very few people know that PTG is post-traumatic growth. How can I get better than I was before this bad thing happened? So the goal is to get to PTG. Your specific question is, though, what goes on through your head and why you do that? There was a great book that I read that talked about the 3 Ps, and those when bad things happen. Number 1, the first P is personalization. This was my fault. And especially in surgery, I threw a bad stitch, I threw a bad knot, I didn't operate when I should have, I operated when I shouldn't have, different things like that. It gets to be very personal. The next nasty thought that goes through your head, and this one to me is the most insidious and the hardest one to overcome. And my guess is that you guys will nod your head and agree that you've had this even in your own life, is what is known as pervasiveness. So when I had this awful complication that I started off my book talking about that started me down this road, the pervasiveness is I had a bad outcome, I'm a bad surgeon. Then the pervasive, if I'm a bad surgeon, I'm just overall a bad doctor. And I'm probably not that great of a husband either. And I'm probably not that good of a dad. And I'm not that good of a friend. And you could just see that it spirals out of that one bad thing invades other aspects of your life. So that's the second P. The third one is permanence. I don't know if your parents ever joked with you about like this is going to go on your permanent record. I don't know if you ever got those threats or not, or if you still have them even at your age.
Yeah.
That this will never leave. I will always be the person who caused this complication. I'll always be known as this doctor or this surgeon. That is what is going on in people's brains or surgeons' brains, proceduralists, anybody when they make mistakes. Those 3 Ps. The people that go on to PTG to try to tie together the first thing that I mentioned in these 3 Ps right now. If we can teach people that mastery, people who progress to mastery, which by the way, mastery is one of the 3 things that's been shown to lead to professional satisfaction, is the ability to become a master in something. Those who accept that mistakes are part of the process are far more likely to progress to mastery than those who are always trying to avoid mistakes. So that to me is one of the things that I tell people to try to help them break the cycle. Yes, this is hard. This did not go the way that we wanted to from it. And then we go on and we talk about how mistakes unfortunately are part of the process, and now it's a matter of how do we build ourselves back up, and we're going to be better than we were before.
That's awesome. I really love it. So it was personalization, it was pervasiveness, and it was
Permanence.
Permanence. Yes.
Yeah.
So we had a Dan and I a couple months back we had a really great lunch with a. That's awesome. I really love it. So it was personalization, it was pervasiveness, and it was Permanence. Yes. So we had a Dan and I a couple months back we had a really great lunch with a what, medical school dean.
Yeah.
Yeah. And we were talking to them about how kind of going into the subject where there's this kind of level of ownership where they're almost reluctant to ask for help because you got to be perfect. You got to get things done right. Otherwise, you can kill somebody. You can really hurt somebody. There's medical malpractice. There's insurance like there's all of that stuff. And then now, later on, it's like, hey, man, if you're going to master this, part of it is making mistakes. That's part of the process. That seems like that's a record scratching 180. Or am I wrong on that? And if that's occurring, like, what's the best way to kind of start pivoting to that when they're constantly being told, like, you got to be perfect. You got to ace everything. You got to be the best of the best.
Catastrophic. There's a lot of medical mistakes that get graded as level A, no harm, to the patient. As you are going through your progression to mastery, and this isn't always possible though, but fail safely, fail quickly is a great way, I think, to think about that. And then in terms of the asking for help, we used to have a saying in surgery that was, call whenever you need me. Just know that calling's a sign of weakness. And that was kind of the old school surgical that needs to get jettisoned, because when somebody's asking for help, it is incumbent upon the senior people, like, you ask, I come, and so that you're not on an island, and not be seen. In fact, the trainees that I work with, if you give me a trainee who calls all the time because they're not sure what to do, and the one who never calls because they think they know what to, I'll take the trainee who calls, not the one who thinks that they know everything. And again, you think you want the doctor who knows everything and all that stuff. You want the empathetic one who could say, I don't know. Hardest thing to say in medicine. I'm not sure.
Mm-hmm. Yeah. I shouldn't even be right. Like, this concept on the other side is that you have some doctors where I made a mistake and they're like, it's that shame, it's that guilt, it's that personalization, right? I'm a horrible person. I'm a horrible dog owner. I shouldn't even be right. Like, I don't even deserve to live, all that. How about on the other end of that spectrum where someone clearly made a mistake and they're deflecting ownership and you're like trying to coach them and they're like, oh, it's not my fault, or it was this, or and there's kind of that end. What's the prescription for that? Because that could,
and you are not owning it. Is that a accurate way to describe what we're talking about?
That is a perfect way.
Okay. So, time for a brief story.
Let's go.
Okay.
Get my popcorn ready. Yes.
Yeah, gotcha. It's not that good of a story. I don't know. So,
I won't even butter the popcorn. Fine.
Okay, got it.
That is a perfect way.
When I was very young in my career, I was working with a physician who had no insight into their behavior at all. And
I won't even butter the popcorn.
Who that got sent to if you had anger management issues or things like that. And this trainee got referred to this coach to help them because they didn't have insight into their own behaviors, causing a lot of friction. So I find out this guy's name, great guy, name is Bob. And I made an appointment with Bob. And I said, I have got to know, like, what is it that you tell these people when they come in here after you've gotten like these evaluations that they don't have self-awareness and all that stuff. So we're talking back and forth, and I was ready for my $100,000 question. And I said, Bob, can you teach insight to somebody who doesn't have it? And I wanted desperately for the answer to be no. Why? Because I believe that time is the most valuable thing that we have. And if you tell me that if somebody doesn't have insight and it's not a changeable thing, then why would I invest my time into something that's not going to be successful? So I wanted the answer to be no. You with me so far on this great story? Okay.
Yep.
50% on Rotten Tomatoes so far, so we're good.
Gotcha.
No, we're good.
Yeah. Yeah. 3 out of 10 so far. No, I'm
3
kidding.
out of 10.
No, I got you.
You know, it's funny you said. I was just complaining yesterday that never read your own reviews because one person.
We're good. No, we're good.
Yeah. Yeah. 3 out of 10 so far. No, I'm kidding. No, I got you.
So Bob looks at me, and again, remember, I want the answer to be no, because then I can give myself permission to say this is a lost cause and I'm going to move on. Bob said, yes, but it takes a phenomenally long time and moves at a very slow pace. And so to go back and answer your question of what do you do with these physicians, or people in life in general, you have to make some assessments of yourself. Is this a changeable or not changeable behavior? And there's different clues in that, like, has the person ever asked for feedback before? Is the number one sign that they maybe have insight into their own behavior. If they don't have insight into their own behavior, it's going to be really difficult to succeed in that realm. If you do want to try to help them in that realm, you have to keep it all positive. And there's a great theory on this. Have you guys ever heard of PEA and NEA?
Can't say that I have.
Okay.
No.
So it's funny in med. So PEA is also known as pulseless electrical activity, which is when you code and die. So this is not what we're talking about for all the listeners out there. PEA is known as positive emotional attractors, and NEA is known as negative emotional attractors. And if you want to make it really simple, if you're keeping somebody in PEA, positive emotional attractor, you are stimulating their parasympathetic nervous system, which in medicine is known as the rest and digest. If you're in NEA, negative emotional attractors, that's stimulation of the sympathetic nervous system, which is what most people know as fight or flight, right? And that goes back to, caveman saw a saber-toothed tiger, thought he was going to get eaten, adrenaline runs, and I run away, right? In that moment, you are not in a growth mindset. You're not thinking, wow, do I want to name this tiger something? He's cute or anything like that. You're running away so that you don't die. Or PEA is the opposite of that. That is when I'm in a growth mindset. And if you want to try and help somebody who doesn't have you have to keep it positive. So I'll share with you my go-to line that was kind of taught to me. When somebody has a behavior that is hampering their career or hurting things, what would be the benefit to you if you got better in this area? And I'll say that again. What would be the benefit to you if you got better in this area? Now it's all positive. Now it's, hey, you're here and I want to help you get to up here. So if we're talking about a complication or not taking responsibility for something or your communication style, we could say now I've kept it positive. You're not in fight or flight, sympathetic nervous system. The caveat to what I just said, it takes a phenomenal amount of effort. And now you're giving up the thing that's most important to you, your time. So I hope that wrapped it all back together there and actually answered your question.
Yeah, no doubt about it. I think one of the things too, it's just interesting as you're talking, obviously listening to you, but you're also making me think of some things from when I was younger, and I wasn't doing surgery, but I was treating patients. I was a physical therapist, and I think about that. There's still that one patient, the first patient I remember. I did everything. I think one of the things too, it's just interesting as you're talking, obviously listening to you, but you're also making me think of some things from when I was younger, and I wasn't doing surgery, but I was treating patients. I was a physical therapist. And I think about that. There's still that one patient, the first patient I remember, I did everything because, we're talking about complication, but then there's the aspect of, all right, what if you actually just do everything right and you don't even get them better, right? And I remember, and I just distinctly remember this case, this elderly lady, super active, to your point about functional activity, so to speak. Like, she's like, I'm playing tennis, I want to keep playing tennis. And I did everything I could to get her better, and I couldn't do anything. And I felt like crap, and it took, and fortunately I had a good mentor, which not everybody does, to be able to pull me aside, like, all right, let's run through, what did you do? What did you adjust the treatment plan? Did you do this? Did you do that? And he's like, you did everything you could. It's just, unfortunately, that's the nature of the beast. Sometimes you don't get them better. And that was something that I had to really grapple with. Like, then how do you overcome that? He's like, you just have to accept that that's the human body. We don't know everything. And, to your point, it took me a while to really understand that. But then as I've gotten older, Antonio, you mentioned, is it just something you develop? I've seen a lot of younger professionals, their confidence is basically sucks. They don't get somebody better and they crater. And then we're talking a lot, obviously, about the negative effects, rightfully so, on doctors. But then I also think about what's the negative effect on the next batch of patients that come after that, right? It's now you're walking into, it's one thing to have a physical therapist who's a little down on their luck, so to speak. But it's like, all right, now I'm operating on you. I'm the surgeon, and my confidence is kind of in the dump. So I think it's patients obviously walking in thinking you're going to get me the outcome here. How do you then, talking to that doctor, you talked about being maybe a little tentative or just having some humility in your conversations. How do you then present it to them of, all right, you might still be struggling, but this is how you need to present yourself to those next patients while you're maybe still not in that growth mindset phase, you're in that PTSD or still recovering phase. How do you present it so they don't know that you are? Sure.
Right here. And inside this bucket, we're going to put 9 red ribbons, and we're going to put 1 green ribbon. You are then going to put your hand in, you're going to pick out 1 ribbon. What color would you predict that you pull out? Being the great mathematician that I am, 90% chance that it was going to be red, 10% chance it was going to be green. Red. Because, of course. And then he looked at me and said, if you picked the green one out, was your thought process wrong, or did you just have a bad outcome? I was like, well, obviously red was the correct one to pick, right? Sometimes in medicine and in life, we can do everything right, and the outcome isn't what we want it to be. You might have done all the right exercises with her to get her the mobility or that she needed, and unfortunately it didn't work. But that analogy helped me significantly. So sometimes I can do a great operation, do everything, and I could still have a bad outcome after that. And when that happens to me, if I had a good process, I go look myself in the mirror and I can hold my head high. That day I did good. Conversely, I also have to the maturity, I've done not great surgery before, and patients can do okay. The human body is very resilient, and that's unacceptable. I got to get better than that. I have to have a good process. Yeah. So that's my answer to dilemma number 1.
Where do you, we're talking a lot about the individual here, and you do a lot of work on the teams. Where does the support team come into play?
Yeah.
Not just from the day to day. Obviously, they're increasingly important, but from the standpoint of, all right, we're talking a lot about the individual here, and you do a lot of work on the teams. Where does the support team come into play? Not just from the day to day. Obviously, they're increasingly important, but from the standpoint of, all right, the main guy maybe made a mistake, or maybe didn't make a mistake, just didn't go right. Where does that team network come into play to actually help get that person back to where they need to be?
Is when somebody else who does what you do comes and gives you support. And that is, so when you talk about having the team, it's not always, the trainees that are with me, or, other people on the staff that are taking care of the patient. I always tell people, when I had my worst complication, my wife, my best friend, we've been married 16 years at that time, not in medicine, and didn't understand what I was talking about when I was describing how I misinterpreted the anatomy and this happened. She knew I was sad. She wanted me to feel better. But it wasn't until I went and talked to my old chairman, another general surgeon, and I started telling the story of what happened. And he was like, yeah, you want to hear a story? Let me tell you my story. And, I said, that happened to you? He goes, yeah, Danny, it happens to everybody. And when a peer says it, there's nothing more powerful than that. So, yes, the team, but it's your peers. Just like it sounds like you had another physical therapist talk to you when the tennis player, who does what you do makes the biggest difference. Overwhelming. There was a second part to that question, and I don't remember what it is, to be completely honest.
Hey, to break it to you, neither do I.
It must have been important.
Yeah, it's all good. No, I mean, you made a valid point there. What about on the, talking about building a high functioning team? And you're discussing about getting those, because this is definitely break it to you, neither do I. Yeah, it's all good. No, I mean, you made a valid point there. What about on the, talking about building a high functioning team? And you're discussing about getting those, because this is definitely something in healthcare where I don't think we talk about it a ton, but the aspect of how do you get that team to go above and beyond, right? I know that's something that I spent so much time trying to figure out, which, I got there eventually, but I think we just assume, hey, you got into healthcare, that means you're going to be all about taking care of people. But then the reality is that it's not. So for those people, especially there's owners out there who are saying, I can't find good employees, or the people that I have, they're not motivated. Speaking to that person, what would you say regarding, here's how you get your team to really function at a high level when it relates to, what you're doing in healthcare?
Paul, I can go back and see the patient one more time because it didn't seem like they totally understood, what I was talking about. Going above and beyond, that has been definitively shown to be the secret sauce of what gets highest functioning teams. Give discretionary effort. Okay. How do you get somebody to give discretionary effort? Great question. You have to create, and everybody loves this term, but we're going to dive into it a little bit more. You have to create what's called psychological safety on your team. And everybody loves that term, but very few people know there's actually 2 ingredients that go into creating a psychologically safe environment. And if we had more time, I'd pimp you both on them. But then, I'd be seen as a hostile surgeon and all that stuff. So I'll just tell you the answers. Number 1 is what they call ostentatious listening. If you want your team to be a great listener, be a great listener. Learn how to make eye contact with people. Say back the last 2 or 3 things that you said to them. Ask good, open-ended questions that show I'm invested in what it is that you have to say. Be a great listener. Create psychological safety. Number 2 is what's known as equality and conversational turn-taking, meaning that when you're in a team, everybody gets a chance to speak at about the same rate. Then you know that there's not somebody sitting in the corner who's got a great idea and is unwilling to share it. If you have those 2 things, ostentatious listening, equality and conversational turn-taking, that leads to psychological safety. When you have psychological safety, your team will give discretionary effort. When your team gets discretionary effort, your team will function at a high level.
I love it. What I wanted to do was kind of pivot over into not in another direction, but I have a really quick question. I'd love to get like a quick answer. Do you feel like enough medical professionals are love it? What I wanted to do was kind of pivot over into not in another direction, but I have a really quick question. I'd love to get like a quick answer. Do you feel like enough medical professionals are getting kind of psychological help on this when there's things that go wrong in like the operating room or in their clinic? Do you feel like there's enough that's happening, or there's more that are suffering quietly?
to give me a call, and then you reach out to them. Sometimes they don't even return your call. The resources exist, but what is it? You can lead a horse to water, but you can't force it to drink. I do think, though, there's still stigma out there. Negative mental health, can't handle this yourself. I do think there's the silent sufferers that are still out there, but I do think we've done a better job of acknowledging we need trained people who can help with this, because this is hard.
So it doesn't sound like it's like a 50-50 where it's like, half of healthcare is kind of quiet and the other half is they're actively seeking help. Do you feel like there's one in the majority and one in the minority?
I don't know the answer to that, to be complete.
So it doesn't sound like it's like a 50-50 where it's like, half of healthcare is kind of quiet and the other half is they're actively seeking help. Do you feel like there's one in the majority and one in the minority? Yeah. Because kind of where I'm going with it is I wonder when people leave healthcare because they're burnt out, how much of it, because burnout is a couple of factors that the individual can then feel like, all right, I am quote unquote burnt out. How much of it is, it's potentially like workload, but also the psychological distress of just not getting help. So that's kind of where I was going with that.
Reading a lot of the burnout has to do with a lot of the things that are what I consider to be non-value add to the doctor and the patient, i.e. like paperwork and
like administrative
administrative tasks that don't, dear Dr. Eiferman, could you clarify, was this present on admission and what type of, sepsis was this? And you didn't write the admission date on your H&P. Could you please go back and addend it, and things like that? And it's like, this is not what I want to be doing. Or you're not seeing enough patients in clinic, and we need to cut down from 15-minute visits to 5-minute visits, things like that. Decreasing reimbursements, I think, are like that burnout thing is a pretty multifaceted thing.
Yep.
I'm not certainly bad outcomes, stress, and all that stuff is in there, but I don't know if it's the majority.
Yeah. When you're talking about psychological safety, and when you said when you're obtaining your MBA that you got a really great lesson from the accounting professor, I'm curious, what lessons from the operating room translate directly into business and leadership in life? What are things that you learned there? When you're talking about psychological safety, and when you said when you're obtaining your MBA that you got a really great lesson from the accounting professor, I'm curious, what lessons from the operating room translate directly into business and leadership in life? What are things that you learned there that you're like, this is helpful here with anybody? Damn right. Yeah. See, he says he likes my questions. Yeah.
Yeah.
No, okay.
Funny.
Yeah.
Put that line together.
No,
Yeah.
I'm kidding. Yeah. It's going up, man. It's getting gold here soon.
You're trending.
Yeah.
Trending positively.
3.5 now. But I love that, because it's just there's so many great golden nuggets from people in hospitality, or they're in technology, that there's really great principles that they learn there that just should be out a little bit more public facing. I'd love to hear any of your thoughts on that.
Trust means everything. We only accept feedback from people that we trust. We will only feel psychologically safe around people that we trust. So now you have to go back and say, how do I build trust? And this answer may surprise you a little bit, but it does. You asked me for an example from the operating room. And this is the scenario that I give actually on the very first day of the leadership class that I teach on tenets of high functioning teams, is that as you walk into the operating room and you don't know anybody to do an emergency procedure, how can you quickly form a high functioning team with people you've never worked with before and you've never met? And I give that activity to the group, and they come back with different things. And what I share with them is the number one way to get them to give you trust, to build the psychologically safe so they'll go above and beyond, is to show your vulnerability first. So when I walk in there into the operating room, they say, hey guys, have you ever done this procedure before? And you're like, no, or you're something like that. And the very first thing I'll do is say, listen, you cannot screw this up worse than I already have one time in the past. Now I'm a human being, okay? I'm not somebody who expects perfection or some machine, anything like that. I can show I'm not perfect. I've screwed this up before, and I will understand that if you don't get it right the first time. And when I tell people, this is a made-up statistic, but I really believe it, 95, I think, to 98% of people that you drop your guard first and show them your vulnerability will reciprocate by dropping theirs as well. And now we have a connection together. And I always put the caveat in there. There are those 2% of people who will burn you. It's a little bit of a risk. And those people have names. Okay? Those people are assholes. Okay? And they exist, but I don't feel like you can live your life that way. So what's my thing from the operating room is I go in there and I drop my guard first. And I share some sort of vulnerability, something that I've screwed up before, so everybody knows like mistakes happen. We're only going to get to master if we make mistakes. And if I do that and I create that environment that I've now gone on, again, I'll be great listeners to them. I'll include everybody in the room. I've made myself vulnerable to build trust. Hopefully I've created a psychologically safe environment. And when I've done that, now my team, even though I haven't met you before, are willing to go out and do something, go above and beyond. And now we're going to have a high-functioning team. So that's my example from the operating room.
Shifting a little bit, I'm just curious, how much you're invested in this topic, but there's definitely been some chatter about how much AI and robotics are going to play. Shifting a little bit, I'm just curious, how much you're invested in this topic, but there's definitely been some chatter about how much AI and robotics are going to play a role in surgeries. Not that far down the line in terms of, so I'm just curious to know what your opinion on the role that AI and robotics has in surgery. Because I know there's been some ridiculous tweets, to me at least, where it's like, doctors won't even have to be doing surgery in 5 years, which I think is kind of silly. But I do think there's obviously, you already see robotic assisted surgery. So what role do you see the technology playing in surgery? And then second part of that would be if it takes some of the, not skill set away from the doctor, but maybe what skills would you say, hey, if AI is coming more into our realm, these are the things on the human side you should probably double down on to help differentiate yourself?
That the outcomes are better. Let me ask you this, because I used the joke earlier that neither of you laughed at, by the way.
I laughed on the inside, Danny. Come on.
You laughed on the inside? Okay. Remember how I said good judgment comes from experience, experience comes from bad judgment? Mm-hmm. Okay, good. Now at least you're laughing out loud now. So I've done a couple thousand operations in my career.
Laughed on the inside, Danny. Come on.
Yeah.
I laughed.
Of how things are supposed to look like when you do the same procedures over and over again. What if you had 1 billion operations programmed in? Who's got a better mental model? I would probably vote with the guy that's got 1 billion in there. And where I see this going, and what I'd like to see it's going, is if I'm doing an operation and it's having difficulty identifying the anatomy, can the technology get to the point where it would be like, warning, don't cut that, or aberrant anatomy, or something like that, because it's got 1 billion things sit in there, which is a lot more than my couple thousand.
Sure.
I think we should be embracing that and targeting things. I will tell you, and this is the super cynical American in me, I will still be doing surgery in 5 years because of one word: liability. When something goes wrong, somebody want people to sue. Okay, and I will tell you that the robot companies aren't going to assume the liability for doing the case. So I'll still be doing surgery in 5 years, probably 10 years, probably, and all that stuff. I don't think that's going anywhere else. The second question on the AI actually doesn't have to do with the technical operations anymore. To me, it has to do with research now, and that is, it used to take forever to write a research paper. You gathered the data, or you did clinical experiments and all that stuff. Who's the author now if you can just dump something into Chat GPT and 30 seconds later a manuscript comes out? And I don't know where that's going. And is that my work? If I just pulled up Gemini and said, here's the last 100 of these we did at Hospital X, analyze it, put a graph on there. Is that reliable? That I don't know where we're going with that. That's the negative. The positive AI, going back to the administrative stuff that we saw earlier, some of you I've talked to, like I already have in clinic, like what we call ambient listening, where the thing's like listening and it writes the template of my note, and the primary care doctors have said from that it can like put out the orders like, oh, you're old enough that you need a colonoscopy or a mammogram, and this is the billing code that we should use for this. I think that could be a significant positive of taking away the things that doctors don't like doing. If this stuff is really as good, and it does look like it's that good. So that's my robotics and AI question. Hopefully that answered your question.
Yeah, no doubt. What do you think for the doctor who's just listening, not even a young doctor, just anybody who's practicing and they're along your lines where it's like, I got 5, 10, maybe 15 years left in this game. What are some skills from a purely personal think for the doctor who's just listening, not even a young doctor, just anybody who's practicing and they're along your lines where it's like, I got 5, 10, maybe 15 years left in this game. What are some skills from a purely personal leadership aspect would you say, these are going to be the top 2 or 3 things that you really should be working on over the next few years?
Along somewhat of the same lines, how to be a great feedback giver and feedback receiver. Those would be the skills that I would focus on from a leadership standpoint, and how to develop people.
I love it. I want to give you some rapid fire questions. You ready? You good for that?
Are any of them on sports? Because that's what I'm really good at.
Yeah.
Who's the better football team, Ohio State or Michigan? Just kidding.
Yeah, right. We'll get them again this year. We got a heck of a team.
I want to give you some rapid fire questions. You ready? You good for that? Yeah.
Who's the better football team, Ohio State or Michigan? Just kidding.
By Daniel Pink. If you remember earlier in the podcast, I talked about mastery being one of the 3 things that leads to professional.
So a couple of rapid fire. What's a couple of books that have influenced your leadership style?
About performance improvement. And another one that I really liked was Range. And I'm blanking on the author on that one. But the premise was, we do this in medicine too, like if you study one thing and just breakthrough, then if you try a little bit of this, try a little bit of that, try a little bit of this, and then you say, you know what they're doing in urology may be applicable to what I do in general surgery or neuros and all that stuff. And if you have a range, you're actually more likely to come up with a big breakthrough. Those are the top 3 that come to my mind right away.
I like that. What's one thing young physicians should stop worrying about, in your opinion?
How much money they make and titles.
That's a good one. And what's one trait healthcare needs less of? I like that. What's one thing young physicians should stop worrying about, in your opinion? That's a good one. And what's one trait healthcare needs less of? Less.
I quote it as, I learned how to talk to myself nicely. When people come to
What's one habit that has improved?
you control your thought process. And that was the second part of the question. from earlier. Uh, it was how to get people to bounce back is, and what you say to them is, you could say things, you're still going to feel terrible. And there's data out there that says you have a bad outcome, it's going to take 63 days before you feel good again, which is about right, or what I've experienced, in my opinion. But I've learned to talk to myself nicely, where I say things like, okay, that didn't go the way that I wanted to, but I have the skills and the education to significantly make people's lives better, and I'm going to continue to do that. And versus the 3 Ps that we talked about earlier, I suck at this, I'll never get better at this, I shouldn't be doing this. Learn to talk to yourself nicely.
And this last one is, I always like hearing it from different people. From where you sit, and I'm going to keep it rather vague, from where you sit, what are your predictions for healthcare down the road? If you had a crystal ball, you're like, I think this is what's going to happen. And this last one is, I always like hearing it from different people. From where you sit, and I'm going to keep it rather vague, from where you sit, what are your predictions for healthcare down the road? If you had a crystal ball, you're like, I think this is what's going to happen.
Is what I think. The numbers on the shortage of doctors that's coming up for the aging population, that's what I think that mid-level provider. I don't think we're supposed to say mid-level providers. Advanced practice providers. Can you edit that piece out?
I don't know, man. That's probably one. Yeah, like what's the one thing that's changed in healthcare? It's probably just the obsession with what we're titles and what we're called.
Yeah,
it's not even just, I need to be this person. Like, don't call them that. It's like, dude, just worry about the outcome, huh?
Yeah.
All right, so if somebody said to you, hey, look, Danny, I don't want to watch the episode.
Yeah.
I don't know, man. That's probably one. Yeah, like what's the one thing that's changed in healthcare? It's probably just the obsession with what we're titles and what we're called. It's not even just, I need to be this person. Like, don't call them that. It's like, dude, just worry about the outcome, huh? All right, so if somebody said to you, hey, look, Danny, I don't want to watch the episode. Tell me major takeaway. You know, if I'm an owner, I'm running an organization, what would you say is the biggest lesson you want them to take away from this conversation?
Is a big one. If you really want your team to find it, learn how to get your team to give discretionary effort, the above and beyond.
It's just saying, love it.
Go Spurs, go.
Yeah. Nah, I mean that's perfect. You know, I mean like that's I love it.
People and all that stuff. Those are fun teams to be a part of.
I will say I've thankfully been a part of a team like that, and to your point, it is actually fundamentally amazing. It really does make going to work a hell of a lot more enjoyable. The patients pick up on it. You know, that's one thing. Patients are very observant. They can tell when you don't have that, right? And I will say I've thankfully been a part of a team like that. And to your point, it is actually fundamentally amazing. It really does make going to work a hell of a lot more enjoyable. The patients pick up on it. You know, that's one thing. Patients are very observant. They can tell when you don't have that, right? And it's just, so I love that aspect. You know, and I really think as we kind of get into a close here, the one thing I would, you know, probably add a little bit to what we talked about too is I think a takeaway, honestly, even just based on this conversation, is just the responsibility that organizations have with regarding, you know, cultivating that kind of, we didn't even, I don't think mention the word, but cultivating that culture where, you know, you have the trust, you have the vulnerability, but then understanding too that a lot of people, to your point, don't automatically go to that PTG zone. They kind of stay in the, I feel like, crap zone. So it's also figuring out how do I create leaders within this organization that can support the people that we're all working with? Because again, this whole conversation was about, you know, surgical mistakes, but people just make mistakes in general. And nowadays, we're not the most resilient. You know, a lot of it's just we make one mistake and it's, well, I suck, so I should just quit or whatever it is. So it's being able to, how do we develop that kind of growth mindset culture, that leadership culture that is going to support people and support our doctors and professionals and providers and clinicians to get better and better and to really help each other on this journey, so you have that discretionary effort. So I think that's probably the best takeaway for me on this conversation. Doctor, this was amazing. We could probably spend like easily a few more hours, do Joe Rogan style, but I really love it. How do people connect with you? So if they're watching or listening and saying, hey, I want to start working with this guy, maybe start fixing some stuff that's happened to me in the past that I haven't gotten over, or just prepare myself better.
Your book too as well.
Barnes and Noble and all that stuff. And the book has all the take-home messages. If you don't, like, if you're the type of person who just wants to read the executive summary, you can just go to the back. And but if you like the stories and all that, so The book is out there. If I refuse to do any social media because I think social media is the devil, but the marketing people that I worked with for the book said I had to be on LinkedIn, so I am on LinkedIn. It's what is it? If a tree falls in a forest and nobody's there to hear it, the tree needs a better marketing plan. And so, yeah, I got you to laugh on that one.
There you go.
And then my website also has, if you really want like to email me or continue the conversation, podcast, give a talk, seminar. It has all my lectures on there and all that stuff. Is Integrity Surgery, one word, integritysurgery.org is the website that the people built for me. So that's the book, that's the email, that's the website. Yeah.
Well, I got to say, Doctor, yeah, it was an absolute pleasure having you on. I learned a lot. And then also just really thank you for what you're doing. I have a lot of family in healthcare personally. And what you talked about today is not only applicable. I got to say, Doctor, yeah, it was an absolute pleasure having you on. I learned a lot. And then also just really thank you for what you're doing. I have a lot of family in healthcare personally. And what you talked about today is not only applicable to healthcare, but it's applicable to a lot of other industries and a lot of other sectors. And so just that really great points of view. And just thank you so much for jumping on. Really appreciate it.
Is the least acceptable activity that we accept. So if you want to build the right culture, so if we spent this whole podcast interrupting each other and nobody called anybody out, then we accept interrupting. The culture of this podcast is interrupting. So if you could take that to, if we scream at somebody, everybody that they have a complicated or don't do something perfect, and nobody says it, that's our culture. But when we call it out, and if one of you would have said, hey, please let him finish, and all that stuff, that to me is how you define somebody's culture.
Love it. You get what you tolerate. That's for sure. Pleasure. Guys, this was an amazing conversation. We will see you next time.
Bye, everybody.